Evening. My name is Uma Srikumaran from Johns Hopkins University School of Medicine. I'm going to be talking about the options and role of grafts for massive rotator cuff tears. My disclosures are available online. So with respect to this challenging rotator cuff tear, specifically large and massive tears, what exactly do we mean by this and how do we define that? And is that the same thing as an irreparable tear? And what are our options in that case? Particularly when we're talking about pseudoparalysis, how does that play a role in how we manage these tough rotator cuff tears? So what are the options? Of course, we consider who our patient is specifically and what our goals are in order to treat and manage their injury. So first, with respect to massive versus irreparable tears, they're obviously not the same thing. If you have an acute traumatic massive tear with good quality, minimal retraction, and reducible with very low tension type repair, this is directly repairable and advanced techniques aren't necessarily required. When we speak of massive tears, it's not just the size that determines this. We're often speaking of the quality of the retraction, the level of the retraction of the tendon, the level of atrophy or fatty infiltration, and even the tendon length that remains. It gives us an indication of chronicity as well as size. And additional factors include pattern, the location, whether the force couple is maintained, as well as function. Again, respect to pseudoparalysis, the ability to elevate actively beyond 90 degrees and whether full passive range of motion remains. So we've recently defined this through the American Shoulder and Elbow Society, trying to come up with a consensus statement, and they came to an agreement that retraction to the glenoid rim and or 67% or 2/3 of involvement of exposed greater tuberosity defining a massive tear. So when we have this situation, a large tear, what are the options? Of course, we have non-operative options, tenotomy, debridements, partial repairs, rotator cuff repairs with these patches and grafts, tendon transfer, superior capsular reconstruction, balloon now, reverse shoulder replacement. And then we try to match these options, surgical options, with these varied presentations and locations of tears. So today I'm going to specifically focus in on this area, patches and grafts, and then a little bit touching on how a graft can be used in a tendon transfer as well. So what are grafts? So there are two main ways these can be used: in a bridging configuration or as augmentation. Autograft, so the categories include autograft, allograft, and synthetic graft. So autograft most commonly includes biceps tendon as well as fascia lata. Allografts most often include human dermal tissue and synthetic polypropylene substance. And finally, xenografts, varied kinds of tried, particularly bovine pericardium and porcine intestinal submucosa. However, this graft was looked at with a randomized controlled trial, and we don't have a lot of these for this technology in general, but is not recommended to use this porcine xenograft that had significant inflammatory reactions and did not improve healing or clinical outcomes. So that is no longer used, and we won't be discussing that. In general, however, what is the goal of these graft tissues in the use of rotator cuff repairs? Obviously, we're trying to increase that initial strength of the repair. It's very important to protect the repair, minimize that gap formation. It may also be used to enhance our ability to hold the number of sutures that we'd like to place in the tissue. We want to promote scarring and promote tissue ingrowth. And we wonder if some of these grafts can be biologically active. And ultimately, we want to transfer that force or stress of the repair from that graft tissue to native tissue or healing or scar tissue that is formed. We want to do all of this without having an inflammatory response that may lead us to suspect some type of infection or some deleterious response of the host, causing pain and difficulty with function. So just briefly, bridging grafts are those that are secured to the rotator cuff tendon and that bridges from that remaining cuff to the greater tuberosity footprint on the humerus. There's quite a few studies on this, and overall the healing is quite varied, from 58 to 100% in this recent study in AJSM. But again, we're going to focus more on augmentation grafts. And most commonly, it's this alloderm. And these alloderms are typically a human acellular dermal matrix that is meant to allow for some rapid integration, cellular repopulation, and revascularization potentially at the surgical site. And it's designed to maintain this more structurally intact extracellular matrix. It's closer to human dermis and it allows for a low inflammatory type response. So the question really becomes, can these grafts provide superior tendon healing, one, and two, improved clinical outcomes? So this was a very nice study, that a meta-analysis that looked at multiple studies in the past decade or so, looking at tendon healing rates by MRI and ultrasound and clinical outcomes, including pain and patient-reported outcomes, as well as forward elevation as a functional outcome. So overall, there was fair quality in terms of the overall studies that were included in this analysis. So in the graft group, there were over 242 repairs compared to 185 repairs without any additional graft augmentation. It's important to consider this patient, as on average, was 62 years old, with over 2 years of follow-up in both groups. So before we consider the results of this study, it's very important to note that the limitations of many of these studies are that they are non-uniform, in that their tear size and clinical setting are quite different. There's differences in the fixation techniques. There's inherent bias in patient selection, and we're unable to further stratify by indication or fixation technique because of the small number of studies that exist. And this is only generalizable to the primary rotator cuff repair. That being said, however, when we look at these different studies, as you can see, largely performed in this past decade, we're talking about different grafts, allografts, as we spoke about, human dermal, autografts, xenografts, and synthetic constructs. So when we look at this overall, the graft group did tend to have a higher healing rate than the control group. And this was significant, especially when you exclude that porcine group study, which nobody uses anymore because of the poor outcomes. When we look at pain, the graft group also had significantly superior outcomes when we used the synthetic group as the control group. However, there was no difference when we looked at the xenograft group as the control. So no difference with xenografts, but some difference with synthetic groups. The UCLA score, similarly, the graft group had significantly superior outcomes compared to the synthetic group, but no difference with respect to xenograft, and similar outcomes with forward elevation. So in order to summarize, graft augmentation with respect to healing, superior to than repair alone. With respect to pain, UCLA score, and forward elevation, when compared to synthetics as a control group, there was no difference. There was a difference with synthetics, but no difference compared to xenografts. So when we look at another systematic review with respect to healing, allograft had an 85% healing compared to repairs done without that dermal allograft. This was an observational study. With respect to xenograft and native repairs, the healing was only 27%, so not as good as repairs alone. And then finally, synthetic grafts also had a very high rate of healing compared to repairs alone in another comparative study. So a new patch that you may have heard about is this Regeniten bioinductive implant from Smith and Nephew. And this is a case series only, level of evidence is 4, but it did show high healing rates, 96%, with approximately 10% clinical failures. Good thickness was noted on ultrasound, and the ASES scores were 80. And this is a high volume surgeon, very skilled, obviously, so it's unclear when compared to a control group, as these were all fully repaired tendons, what the outcomes would be and what the incremental benefit is of this type of graft. So more to come on this type of graft and the newer options currently available. So in summary, I think the goals of graft augmentation are to improve the biologic aspect and biomechanical strengths of our repairs. However, not all grafts are created equal. So it's very important to consider the graft material, its type, and even the thickness of an individual graft. Dermal allograft, for example, from 1 millimeter to 3 millimeters thick can be quite different. I would express extreme caution with xenograft. Our experience with historical grafts are poor, and there's this risk of stiffness and inflammatory response that seems to occur, even if compared to some of these recent grafts and how they're processed may all affect this type of response. I think the best evidence comes from dermal allografts and their use as augments to our rotator cuff repair. Another interesting area, which I'll briefly touch on, that uses grafts that can extend a tendon transfer is this lower trapezius graft, as described by Dr. El Hassan and extensively published on. This can provide an enhanced benefit to direct repairs. As you can see, the improvements in SSV and DASH scores are quite good, including range of motion, particularly if they've maintained a preoperative forward elevation over 60 degrees. And I think that at this time, you have more and more studies coming out that this type of tendon transfer, again, using a graft now with a new muscle, the lower trapezius, can enhance our outcomes. In this case, Achilles tendon augmentation is typically performed. However, now our preferred approach is to do this technique with arthroscopic assistance for the graft insertion, but without any use of anchors. It can be done completely transosseously. And we use this Achilles tendon graft as is originally described, and it eliminates the expense of anchors, but also eliminates the bone space required to place additional anchors. This is often a revision situation. So a simple device can allow you to place these tunnels as shown here. And we'll just briefly review the approach with this case study. We can harvest the graft here. You can see the small incision made transversely just below the superior scapular spine to harvest this lower trapezial area. So we make an incision there and expose through the subcutaneous fat and slowly then develop that corner of the lower trapezial tendon. We palpate the scapular spine to note our presence. Here we've identified that lateral border of the trapezius tendon. And then we again feel for the scapular spine to release only the lower portion of the trapezial tendon right off the bone. We tag that corner for later incorporation with our Achilles tendon allograft. We develop the plane both above and below the trapezial tendon. We protect the accessory nerve, so we only perform blunt dissection inferiorly and continue to release it on both portions, increasing its excursion and getting it prepped for our graft incorporation. And then we enter into our arthroscopic portion of the case where we will do the passage prep for the graft as well as the tunnel prep in lieu of anchors. So here we are viewing from laterally and exposing the scapular spine on its undersurface. You see the large tear with a poor tendon remnant. We're developing our passage for the trapezial graft and Achilles tendon all the way underneath the deltoid muscle and just exiting medial to that where we will advance. So here's the greater tuberosity. We're exposing it so we can see again from laterally. Then we'll switch to a posterior view and we can view from this perspective and place our tunnels. So the tunnels are placed very similar to where you would place a medial row of anchors. You make your pilot hole, your vertical hole into the tuberosity, one anteriorly and one posteriorly, just as you would in a double row type fixation. This is the hook device that allows you to place a tunnel instead of an anchor. This device enters from the anterolateral portal. You can insert it into your vertical pilot hole, and this will then connect a lateral tunnel with the vertical tunnel. And then a suture is passed that allows us to place our definitive tape sutures here, both blue and black. And then we repeat these steps for the anterior tunnel. This is the posterior tunnel with definitive tapes in place. This is our anterior tunnel that we're connecting now. Again, a suture is passed, definitive tape sutures are placed. We then grab these sutures from the medial exit entry and bring them through our trapezial Achilles graft passage posteriorly to our harvest site. And we interlock these into the graft of the Achilles tendon. And once that is performed, we can parachute the graft into this space by pulling on the lateral sutures. And that is demonstrated here, where the graft passage is widened with a clamp. And then you can see the Achilles tendon coming in that has some locked sutures through it. And we're pulling these sutures laterally to parachute it into place nicely over the greater tuberosity footprint. So you can see the graft has come in now. It's angling through the posterior passage. Now you see these suture tails that we simply have to tie. No additional suture anchors or rows are needed. We grab the sutures from the graft and a suture from the lateral tunnel there, as you can see here, one from each side. The colors are matched. So we grab a blue suture from the lateral tunnel, and then its matching set that's been locked into the Achilles tendon allograft. And this is tied down for a solid repair without anchors of our graft tissue into the greater tuberosity. And these steps are repeated with 2 tape sutures from each tunnel, achieving a good medial to lateral fixation of the graft into the greater tuberosity. Once we're satisfied with our fixation, we just irrigate the joint, and then we focus on securing the graft into our trapezial lower trap muscle. That's it. So how do we decide on what grafts to use? Often we're considering age and functional demand or someone's frailty. On the younger end of things, higher demand, we're trying very hard to do a primary rotator cuff repair and adding maybe a patch or graft to enhance our healing. SCR is a consideration, but our preference now is the tendon transfer with this Achilles tendon autograft to extend things in situations where we cannot get a primary repair or we feel like a graft is not appropriate. Partial debridements, reverses, and balloons we're leaving for a lower demand, older aged individual. And we'll often have to consider costs when we make a final decision. Thank you for your time. I'd be happy to take some questions at this point.